colleagues in Turkey. Thank you so much for following us and following this presentation. We would like to talk about a topic again getting popular in recent years, hip resurfacing. We will talk with Dr. Damien van Quickenborne. He is working at Ghent ANCA clinic with Dr. Hapa in recent years, hip resurfacing. This is the most experienced center for hip resurfacing. Please correct me, Dr. Damien. They did approximately 10,000 resurfacings.
I think that's something about that, yeah.
We would like to talk controversial issues. There is a huge bias for resurfacing in my country, for example. We will talk whether there's still a place, especially in young osteoarthritic hips. We will talk about the learning curve, the most biases about the metallosis issue. How long do we have to follow the patient? And surgical technique. Now, I know some centers trying to do it anteriorly. Do we have to do it posterior or anterior? Usage in avascular necrosis, for example. Ceramic and ceramic last couple of years. I know you had the highest experience, started to be used at ladies. I checked a little bit about the literature last night, and they say at meta-analysis, the functional scores at least are same with total hip arthroplasty, but some of them still say at least same or higher. They try to explain this with ceiling effect of the scores, or the functional scores do not measure the physical activity. They only ask about the pain status. And for example, return to sports, especially high-level elite athletes, we will see the beneficial effect of resurfacing. Overall, they say 10 years revision-free stages at least 95%. And I saw one international study, they say 20-year survival rate for highly used brands. They say 90% of survival for hip resurfacing. And last is revision is really easy. If we have to do a revision, is it easy for us? These are the most we are curious about questions. Thank you so much again, Dr. Damien. It's your turn. You can start.
Thank you, Onur, for the introduction. You asked a lot of questions. It's
because we don't know anything.
But I'm gonna try to take you on a path. Sometimes I'm gonna go maybe too quick over the subjects, but interrupt me if it's not clear. Ask questions if you want to ask questions. First of all, I'm going to start with talking about hip resurfacing throughout time, through our experience. Then afterwards, the second presentation is about a short presentation about the preliminary results of the ceramic on ceramic resurfacing. And third of all, I'm going to show a clip of 8 minutes about our surgical technique, how we use the resurfacing, what approach we use, and how we approach the hip. So to start, I'm Dr. van Quickenborne, like Onur said. So I'm one of the 3 orthopedic surgeons of the ANCA clinic in Rome and Belgium. We have a hospital in Ghent, Knokke, and in Rome. If you see left upside, you see our... Yeah, no, it's not possible full screen. No. So left upside, you see the hospital in Knokke, right side in Ghent, and our newest hospital in Rome, that's Paideia International. Like Onur said, we are a big hip clinic, one of the biggest in Europe, we think. We do almost 1,000 hips. 2022 was a little slower year after Corona. Everything has to build up. But we've done about 850 hip surgeries in 2022. And about 45% of those prostheses were hip resurfacing. So like Onur said, we are a highly experienced center for hip resurfacing. We do about 400 to 500 hip resurfacing each year. But in our center, we see the demand increasing, but we see overall in the registers and in the demand overall Europe and in the world that the decline of use of metal-on-metal hip resurfacing has already been there for about 10 years. And why is that? That is about metallosis. So a metal-on-metal problem we see in resurfacing, and those are dramatically reports. So adverse local tissue reactions, bad prosthesis, systemic reactions. So we see about around 2010, overall, we see the hip resurfacing decline. Now, many lessons have been learned with regard to the factors determining the outcome of metal-on-metal hip resurfacing, but you can roughly subdivide them in three categories. First of all, there's worst results in females. What we have seen about the last 20 years, we see in females a lot of metal allergy. So 1 out of 200 females has metal-on-metal synovial metal allergy. It cannot be tested by forehand. And if you compare it to the males have 1 in 2,000, 2,500 chances of metal allergy. They have more dysplasia. They have smaller sizes, the females. So the female category, the female group that have received metal-on-metal resurfacing have done very bad. Secondly, the surgeon factor is very important. So if the surgeon does a lot of resurfacing or the surgeon does 10 resurfacing a year, the results are different. So surgical experience, volume, and training is crucial. And the last and third factor in the determining of the outcome of resurfacing is the implant factor. We know about the ESR. The ESR was a very bad implant. It has a very steep, very undeep cup. So you have edge loading, whether you place it in 50 degrees or 45 degrees. So malplacement and bad prosthesis, it's a very, very high demand because it's a very thin margin of error. The bad prostheses have gone off the market because of that, and you have in Europe only 2 prostheses we can place. That's the ADAPT or the BHR. All those 3 factors are associated with one of the most important reasons for failure, and that's edge loading. So if you see edge loading, it means that the cup is too steep, and you walk on the side of your acetabular cup. And if you walk on the side of the acetabular cup, it gives too much metal ions, metallosis, and very bad results. But if you have a very undeep cup, like the ESR was, and you place it in 50 degrees, you walk on the edge of the cup. However, the register have shown good to excellent survivalship of certain hip resurfacing, like the ADAPT, like the BHR, like the MITCH, at 10 years, at 15 years, and at 20 years. So you can ask me why hip resurfacing? Why use it in younger patients? And like Onur said in the introduction, first of all, because the survivorship of total hip prosthesis in young patient and active patient is worse compared to older people. If you see a total hip in a 50-year-old, the survivorship is not good. The Swedish hip register has shown dramatically worse results for total hip arthroplasty in patients under 50, age of 50 at surgery. So that's the reason why you should place resurfacing in younger active patients. Like Onur said in the introduction, if you have received a resurfacing prosthesis at age 45 and you want to revise it for what reason whatsoever at age 75, it's a far more easier revision compared to total hip. Also, the British registered survivorship at 17 years for metal-on-metal hip resurfacing combined all diagnoses and all brands in males younger than 50 are significantly better than all cemented metal-on-poly total hip arthroplasty. Still considered a golden standard in the UK, but the resurfacing does better. In 2020, we have together with Professor van der Straten, who's a good friend of us, we have placed a lot of metal-on-metal hip resurfacing arthroplasties of a lot of high-volume surgeons together. We have put it in a meta-analysis, and we have seen that there was excellent results. They have, I don't know results by heart, but it was a perfect perfect outcome for those people with a high group, with a high volume population, high volume surgeries, a big population, and patients younger than 50 years. If you see here at 22 years, in this study, you have almost 90% at 22 years. The most reason for revision were loosening. High ions were 62 patients out of more than 11,000 people. Neck fractures, very seldom. It's one of the, in the literature, if you see in the literature, the biggest reason for revision is neck fracture in hip resurfacing. We don't see it. We see maybe one a year, but it's very seldom. When the worst performing implants, ASR and Cormet, were excluded, the survival results in this study was even 95% at 22 years. So it's a very high survival, better than all total hips in males under 50 years. So another reason to do hip resurfacing in young patients is the restoration of normal gait and higher activity levels. Onur said in the introduction, high impact sports with a total hip. We don't see people with a total hip go running in 3 marathons a year. We don't see them do ice hockey. We don't see them do karate or judo. So that is one of the reasons that high impact resurfacing has a better chance to do impact sports. And the gait analysis shows by Justin Kopp, a professor in the UK, London, showed that the activity is more like a normal healthy hip with resurfacing than a total hip. With a total hip, you avoid loading the operated hip. And with the hip resurfacing, it's more symmetrically loading, a normal gait compared to total hip. A lot of random controlled trials in Europe and Canada have also shown higher activity scores in patients. So to sum up, you can do higher activity sports. You can be active. And to be very fair, you see a lower mortality when you do hip resurfacing. When you do hip resurfacing in patients under 55, they live longer. I was very skeptical with the results of Oxford University in 2013 because I thought it was rubbish. It can't be proven, but now it has been confirmed in the Lancet in 2017. You live longer with a hip resurfacing. So if we decide we should continue to use hip resurfacing in younger patients, what should be the strategy? Because I understand of Onur, you don't do hip resurfacing in Turkey. What should be the strategy to start using hip resurfacing? Well, we have to combine advantages of a hip resurfacing with the bearing couples with proven track records. So we should avoid metal-on-metal hip resurfacing in active young women, small sizes. They have metal allergy. Never do in a tiny dysplastic lady with a cup size of 42, never do metal-on-metal hip resurfacing because they do bad. So we started to think, and we have to use other bearing surfaces. And what bearing surfaces can be used? You can have X-linked polyethylene at the acetabular site. The well-performing materials in total hip arthroplasty are X-linked polyethylene. And we use ceramic on ceramic, hard bearing, hard on hard bearing. So we started to think about 10 years ago, Dr. De Smet thought about ceramic on ceramic hip resurfacing. Colleague of him, Dr. McMinn in the UK, thought about X-linked polyethylene on the acetabular side, all to avoid metal on metal. If you look at the materials we can use, we have less volumetric wear with ceramic on ceramic. So we thought we should develop a ceramic on ceramic resurfacing. It's a higher biocompatibility, and it can live longer because the acetabular site, the polyethylene, is very thin. So the survival will be better with the ceramic on ceramic. So new hip resurfacing designs were developed. The first one is a metal on monoblock cross-linked polyethylene, like I always said. That's called the Polymotion, developed by Derek McMinn, and it's currently used in clinical trials. Actually, the clinical trials has been stopped now for the Polymotion, and they did some changes to the design. Another thing we could use, like I always said, is a ceramic on ceramic hip resurfacing. We have two possibilities: the H1 or the resurf. We use the resurf because it's a development of the adapt of Matorto, and the adapt we use in our clinic. The resurf is an acetabular component, monoblock, highly polished zirconium. So it's a Bilux Delta. It has a press fit cup, so not cemented, and it's a plasma sprayed with hydroxyapatite. The internal geometry is compared to the adapt, so it's not very deep. It has a coverage angle of about 172 degrees. And the femoral head geometry is the same as the adapts. It has a very small antenna, very small stem, so you can't see the stem of a ceramic resurf. And the fixation is by cement. You will see in the clip that I show, it will show the modified posterior approach and the implantation of a resurf implant. Here you see the X-ray of a ceramic on ceramic resurfacing. I will show the preliminary results of this after this presentation. And the study is already going, is still going, and we have implanted over 200 resurfs in 161 patients, and we started it in 18th of March 2021. So we have now we have almost over 50 patients at over 2 years. The overall population is 70% female, normally, because they don't apply to the metal on metal strategy we have now. We don't implant metal on metal in small females. These are the preliminary results of the H1. It's other design than the resurf. It has it has a not even cup. It has a sparing to put in the superior part of the acetabulum to avoid psoas tendinitis. It's developed by Justin Kopp. We don't use this, and since March 2020, the study has been paused because of some loosenings of the cup. So while waiting the results of the clinical trial, it is probably good to keep in mind that even with other bearing surfaces, hip resurfacing arthroplasty remains a difficult procedure. It demands training, expertise, annual volume, and that's the most important thing. Even if you know ceramic on ceramic, the biggest mistake we can make is to tell people, ceramic on ceramic, it's safe. You should implant all hip resurfacing ceramic on ceramic, and it's much more easier. It's much more safer than a metal on metal prosthesis. I don't think so. There is still a risk of femoral neck fracture or head collapse. Edge loading is still a risk that can be avoided. There's a risk of fracture of the ceramic inlay. And yeah, we have to see, we don't know that much. We didn't even put 1,000 implants overhaul the world with ceramic on ceramic. So in our case, we put metal on metal resurfacing in young active males or very high demand females with a big femoral head. And that should be the way that it has to be done. You have to train the people that start doing resurfacing, because without training, you will have disasters. So in conclusion, hip resurfacing rides again in young males and females, and will hopefully demonstrate good clinical results also in women, combining the advantages of hip resurfacing with the advantages of bearing couples with a proven track record. So we have bone preservation, we have rare dislocation in hip resurfacing, we have restoration of gait, preservation of hip proprioception. Biomechanical, it's better than a total hip. It's absence of thigh pain. I don't see thigh pain in total hips, but it's an advantage that has to be shown. Return to active level and high impact sports as possible. More chances to do impact sport with resurfacing than in total hip. And the revision to standard total hip arthroplasty is possible and easier with a hip resurfacing than with a total hip. Thank you. Are there any questions about this presentation?
Hakan, are there any questions? Can I ask you, when I was there, you said learning curve.
Yeah.
Do you have any cutoff number for annual cases?
Yeah, that's difficult. Actually, I can tell you that we are now negotiating about releasing the resurfacing ceramic on ceramic in the total market. And actually, the surgeon has to do over 25 resurfacing a year. And to do resurfacing alone, with training, I think you should do 100 with training. So with surgeon,
once you get courses in Belgium in past years, do you think to continue those courses?
Do you mean the theoretical courses?
Yeah, theoretical course, maybe
Yeah.
a cadaver course in future.
Yeah, we will have a cadaver course in, I think, 2024, April or May 24. And it will be for total hip direct anterior approach, posterior approach for resurfacing, and those two things combined. Yeah.
Wow.
Yeah. So I think that's the way we should do it. If we look at the Netherlands, in 2001, all hip surgeons started hip resurfacing without any training. They just go for it, and they have done in a lot of cases a normal total hip approach. So they have not keeping the soft tissue on the femoral head. I will show you, and they didn't mind about vascularization, and they saw 18% the first year femoral fractures. I think that's because of training. If those surgeons would see that that it has to be done in that way. And there are experienced surgeons. After 10 cases, they see 10 cases do it yourself with somebody next to them, and they will go forward. I think you should do 100 cases to be comfortable. Yeah. And it still remains a difficult procedure.
Yeah. So one last question. This is the one of the biggest bias. They say the metallosis is asymptomatic for years, but when it becomes symptomatic, when you have to revise the resurfacing, it is not like primary total hip arthroplasty. There is a huge tissue damage when you try to.
That's because the patients didn't follow up. The surgeons didn't follow up their patients. I can assure that 99% of our patients with a metal-on-metal hip have blood samples at 2 years, at 5 years, and 10 years. When do we see those horror cases with pseudotumors, metallosis, and very high systemic problems? That's people that didn't follow up. They come after 10 years, you take blood samples, and they have 100 times the normal rate. And then you see those results. In our patients, we revise them when they go up. If we see bad results at 2 years, we see them again at 3 years. And if it keeps going up, we revise them. And then you don't have the rubbish of soft tissue damage. You should follow up your patients.
Yeah. Okay. Because I found you one last question. You said high impact sports is probable. What do you say to your patient if they ask to you, what is the percentage of I am going to run or play soccer after resurfacing?
We have a lot of patients. We had a lot of. First of all, if a patient comes to our clinic and he has no pain in daily life, and he just has pain during sports, and he's not a professional sportsman, then we don't do resurfacing. If it's a professional, then it's another case. If it's problems in daily life and pain in sports, then you can do resurfacing. If it's a male, good bone quality, not a female, not small sizes, then you can do hip resurfacing. And then I say, yeah, you can do impact sports after 4 months post-operative. But running, so yeah, running marathons and half marathon and all those things is the most difficult thing to do with a hip resurfacing, also with a total hip. So I say it's about 80% they can do running and almost more than 90% impact sports, like karate, judo, ice hockey, all those things. Yeah.
In total hip, what do you say? What's the percentage?
Less than 50.
Less than 50. Yeah.
Yeah.
So you offer non-professional athletes when he wants to run or play soccer, hip resurfacing too.
Yeah.
Okay. Thank you so much.
If it's a male and if it's yeah, of course. Yeah. If there's no contraindication for hip resurfacing. But the problem is in our clinic, a lot of people come to us. They are 40 years old. They had 2 arthroscopies, and they have a normal life. They don't have any pain in daily life, but all of their life they have run 10Ks each week, and they have pain now, and it's because of their hip. And they expect from us to do resurfacing on a hip that's not worn out, just to do those 10 miles running. That we don't do it because the results will not be good. When non-professional athletes, they ask you to do resurfacing just to do sport recreational, not a professional sportman, those results are not good.
So yeah, they must have pain at
daily life.
daily life too. Yeah. Okay. Thank you so much, Damien. Thank you again. Hakan, are there any questions more?
Okay. Now,
Yeah, there is one more. There is one question. Sorry, Damien.
no problem.
Kim yazmış? Is it possible to revise a resurfacing instead of revising to a total hip replacement after the resurfacing?
I think we have done that maybe 5 times in 5,000 resurfacings. The only thing you can do, if it's a failure of the femoral head, you cannot revise it. You have to revise to total hip. If it's a loosening of the cup, a loosening in the cup early post-operative, so like you see loosening in the cup 4 months, 6 months after surgery, and you have excluded infection, you can do a tick shell, but that's very, very seldom. Actually, you should take the rule into account that a revision of a resurfacing is going to total hip.
Okay.
Almost every time.
Okay, thank you so much. You are look tired, and sorry about the questions, and thank you again.
I always look tired to you, Onur. Yeah.
Okay, Hakan, there isn't any more questions, I think. Okay.
If you are interested, I will just show preliminary results.
You say there is a 5-minute clip or 10 minutes clip, I think.
Yeah. Yeah. So I'm just going to show, if you are interested, how many resurfs we have done now worldwide. It's 681 worldwide. And you see a lot of females. That's something interesting. You see the divide. You see the very, very small head sizes in females. That's interesting. So you see we have the biggest group. For now, it's only Koen that has done in our clinic the resurf because of the study protocol. Next year, me and Dr. Lohr will start also in the second phase of the study, and I will show you the preliminary results.
And you said there is surgery clip for ceramic on ceramic, I think, isn't it, Damien?
Sorry?
You said there is a clip for ceramic on ceramic.
Yeah, I will show you. So those are the extras.
Oh, there's one more question too. Louis Mason again. You mentioned dysplasia. Do you think there is too severe dysplasia CE angle for resurfacing? Would there be a dysplasia screw design in the cup in the future, do you think?
I don't think so. No. If you see to the H1, it has been designed for this plastic hips with a sparing for the psoas. I think you need a rather deeper cup and a higher coverage angle, and you need a rather deeper cup to have the press fit, because it's a very difficult cup to place to have good press fit. It's you know that ceramic is harder and much less elastic than a metal cup. So the press fit in a ceramic cup is more difficult than with a metal cup. So I don't think we will design especially for this plastic. No. I think very dysplastic hips are a contraindication to the resurfacing. So you wanted to see the clip? I'll show.
Yeah, we are.
Yeah. So I will. It's normally surgery in our In this case, it will take 1 hour in real time, but I will fast forward some steps. If there's any question, just shout and I will press pause and then I will tell you about it. But I will tell what we are doing. But yeah, it's a clip of 6 minutes. Sometimes it takes 10 minutes because I will talk a little bit. But don't be scared to ask something if you want to know something. If you see something you don't understand, just ask. So the first thing we do in the OR after positioning the patient, it's not in the clip, but Onur saw in the weeks he was with us, positioning is key for resurfacing. So it's a lateral, so the patient lies on his side. It's a modified posterior approach. That means that the soft tissues have to remain at the femoral head to guard the femoral vascularization. So the second thing we do after positioning the patient, and it doesn't have to wobble, it has to be solid. The pelvis has to be solid. We have a pubic support and a sacral support. The second thing we do is templating. You should do templating even in resurfacing to see how deep you go. So we have a digital system with a calibrated bowl of 25 millimeters. We calibrate it, and by the rule of 3, we can see how big the bowl is and how big the femoral head is. You can see it on the right side here. It's a 4652 or 4652. That means that's the smallest size for a metal-on-metal adapt. That's why we put here female, small size, and yeah, not that big dysplasia. We put ceramic on ceramic. So you will see a ceramic on ceramic resurfacing. So this is the templating we use.
Did you start the video clip?
Sorry?
Did you start the clip?
Yeah, it's
We
from
can see it. Hakan, can we see it?
Oh, seriously? Oh, wait. Sorry. Oh, okay, sorry. Wait. I thought you already seen it. Sorry. Wait.
Now
Have you seen it? Oh, sorry. Okay. So this is again the templating, calibrated bowl, 25 millimeters with a digitally X-ray, and then we see we have a 4652 outer diameter. So we know we should do a resurf, so a ceramic on ceramic, because that's too small. Female, don't do metal on metal in this case. So, like I said, lateral positioning, modified posterior approach. You will see this in a minute. So this is the incision. The 2 dots you see here and here are anteriorly femur, posteriorly femur. The tip here is the tip of the greater trochanter. So you know this is the head, this is cranial, this is distally. Okay? So incision over the greater trochanter. Go to the fascia of the gluteus maximus. We split the gluteus maximus. You see it here and here. We open it like a curtain, and then we put a charney retractor. This is actually the same as in a classic posterior approach. Then we see the external rotators. Those muscle fibers you see here are the quadratus femoris. This is very, very important because the circumflexum vein is here, and it has a very big, it has to be coagulated and hemostatically perfect because it bleeds like hell. You should leave an envelope of the quadratus femoris against the femur. You have to open it in the belly of the muscle, and we resuture it. You have to be careful. The ischial nerve passes here. So we open the quadratus femoris. In this position, there's the vein. Here, distally, is the insertion of the gluteus maximus. In the beginning, we have released it, but now we never release it anymore. Never. So we have to keep away from the gluteus maximus insertion here. So the quadratus femoris has been cut. Here's the capsule of the hip. The external rotators have been cut. The piriformis as well. Then you put the scissor under the gluteus medius, and then you cut open the capsule. Here's very important with cutting the capsule that you stay on the femoral head. Don't go on the femoral neck because there's the vascularization. Then we dislocate the hip. We see a worn out femoral head, and then we size it. So we have the templating, but we always have the rings, and we put over a 44, 46, so we know, yeah, this is 46, can't pass, so we know that this will be the case, 46, 52. Then the next step is a very difficult step. We have to place the retractor under the femoral head onto the upper side of the acetabulum to remove the femoral head out of the way. Now, you see here, those are the Hohmann retractor on top of the acetabulum. You have a pin on the Hohmann retractor is on 1 o'clock on top of the acetabulum. This is at 11 o'clock. This is on 6 o'clock, 7 o'clock. And we have a third retractor here as well. Sometimes we use it, sometimes we don't. Now we have a good site on the acetabulum. We remove the labrum. After removing the labrum, we start reaming. Important in resurfacing that you have to go from small to big. Don't go too fast. So the first reamer, you go bigger and bigger and bigger until you don't have any rings. But don't go way too big, because in the literature you see that reaming is always too big in resurfacing. In our case, that's not the case. Then we have a trowel. We trowel with 2 millimeters less because we don't have to spoil the press fit. And we have to feel anteriorly that the cup has to be covered anteriorly. So you feel with your finger the anterior board of the acetabulum with the probe. If it's not covered and the anteversion is correct, you have to go deeper. So sometimes I use the probe. I feel anteriorly. If it's not covered and the anteversion is correct, you have to go deeper. Okay, when you feel it's covered and the anteversion is correct, you will see here distally, we use a marker to show what anteversion we use. Then you see here a 52 cup, like I showed in the presentation, hydroxyapatite coated, ceramic inlay, and the impactor. To place it in front of the acetabulum, turn it around, that none of the soft tissue is in between. Place it in the good direction and give it 1 knock. You will see it in a minute. That's a good position. We see the lines are equal, and then we have to knock it. It's very important that when you knock it with the impactor, first impactor, you use a second impactor. Because like I said, the ceramic resurfacing and also the metal on metal are very stiff cups. And you have to hammer it hard that it goes really through the base of the acetabulum. That's why you have to do always second impaction, like you see here. This is second impaction, and you have to really hammer it. If the position is good, you have to remove osteophytes, sometimes a lot, sometimes you don't have to use. Here is his third impaction, very important. That's with a ring. Then you can adjust the anteversion. And after you adjust the anteversion, you have to do second impaction again. Then the acetabulum is finished. Now you remove the retractors and you go to the femoral heads. The femoral heads, it has to be positioned in a good position. We always aim for neutral. So neutral in anteversion on the femoral bone, but also on the femoral head. I always compare it with a cone, with the cone of an ice cream, and you can put your bowl ice cream next to it, but it will fall off. So you put a ring around the femoral neck with a pin, and you have to put this equal with the tibia of the patient. Then on top, this thickness of the pin and the ring is the size we have to remove to put the prosthesis in. That's about 6 to 8 millimeters. So we remove what we place. So we're not lengthening or not shortening the femur. So this has to be equal with the tibia of the patient again, and this is the height we have to adjust. Now, next, we place a pin. This is a lollipop. So the lollipop goes around the femoral neck. This is attached to a shoulder, and the shoulder is attached to the point where we have to enter. So with the lollipop, you always go center. You go in the center of the lollipop that goes around the femoral neck. And that is equal with the lines we have drawn. Then we hammer it in because it has little points in it. And then we drill a bit. A Kirchner, a wired K-wire goes into the canal, and this is the direction of the prosthesis it goes in. Then we have a check jig, so it's marked here 52. Then we click it, and it never has to be notched. So this pin is where we're gonna cut. So if this pin touches too much the femoral neck, you're gonna notch, and you have to replace the pin. So we go around. We attach it, 52, 46, so 6 millimeters less than a 52 cup, 46, and then we go around the femoral neck, and okay. So this is the way we look at it as a surgeon point of view. So K-wire in the fossa piriformis, at the direction of the knee, the lollipop, the shoulder of the lollipop goes around the femoral neck. This is the arrow 140 degrees in the direction of the femur. That has to be templated as well. And those two has to combine with the point we have to enter. And actually then surgery is done. If this pin is correct, everything is guided. So just check it, yeah. So we have made a cone rasp around the femur. The femoral head is now cut. Now we have to remove the upper layer of the femoral head. It compares to the femoral, the line we have drawn. So you have to be careful that this is not too loose. This is about 6 to 8 millimeters. Then we do a chamfer. This is a probe that we have to look at, that everything is equally, that it doesn't notch. And then we put a line where we have to hammer it in, because we can't see through the prosthesis, that we don't know that it's at the end. This is the prosthesis that goes up. This is a cemented prosthesis, cemented ceramic. Then we hammer it in, and you see the line, and this is the end. Then we have to check for toggle, that it's not rotating. And then we have to always remove, almost every time, here anteriorly, you have to remove some osteophytes. This is actually a cam removal, but a little bit more open than arthroscopy. Then we have to rinse, and the reduction, and then it's closing. Capsule closed, quadratus femoris, piriformis closed, and the fascia. This is it in a nutshell.
Thank you for excellent show clip of the surgery. You preserved the capsular insertion, I think.
Yeah, exactly. So we cut the capsule on top of the femoral head. Then you have articular part and the femoral part, and then we resuture it together. Yeah. Very important.
Yeah. And you also sucked the canal when because of the heat.
Yeah, true. That's not in the clip. Yeah, good point, Onur. We drill in the lesser trochanter an aspiration bit. Good point, exactly. An aspiration bit for aspiration the blood through the femoral head. And actually that's as irrigation for the heat, because the cement turns hot and it's an isolated bowl around it. And if the cement goes more than 48 degrees, you get osteonecrosis. So irrigation, rinsing, and aspiration, intramedullary, it's very important. True. Yeah, that's not in the clip. That's true.
Thank you. Thank you again. Hakan, I think there isn't any more questions. Okay, Damien, thank you for this excellent presentation and video clip at the end. So thank you again for maybe we can at least decrease the biases about the resurfacing in the countries like us. So I think it has a huge place at young hip osteoarthritis, and I hope we start young surgeons, probably not me, because of the learning curve, start doing hip resurfacing in my country too. I saw old people at your clinic too, coming to your outpatient clinic and saying, I forgot my hip, that I had hip resurfacing. So it has a huge place at older patients too, but probably at younger patients. And sorry, I talked much. Thank you again, Dr. Damien. I hope we meet at least earlier than 2024, but I will sure probably would like to come at 2024, you said, April or May.
Yeah.
There's a course.
Yeah.
But
actually, to sum up, I think it has to have a place and a good indication. It is a good prosthesis, and it's starting to be a hate game. That everybody has an opinion, and sometimes the opinion is not good clinical results. And you have to be honest. There has been made mistakes, but it's not because one population is not doing good that the other has to be forgotten. So to sum up, everybody from Turkey is welcome to visit us. We want to share our experience. You can come look. We can come to Turkey to help you. It's not a problem. Just ask us. And if you want to come visit us, ask for our contacts through Onur, and you're more than welcome.
Thank you so much again, Damien. And please forward my best wishes to your lovely family and to Dr. Desmet and Delur. And thank you so much again for hospitality and for this knowledge. I hope we meet in near future with you, and take care. Thank you so much. Bye.
Bye-bye.